For erectile dysfunction case, I will first greet the patient, introduce myself, and I will start with the statement of confidentiality. On history, I'll ask an open-ended question. I'll ask the patient to elaborate on what he means when he says he has erectile dysfunction. So I want to know the timing, how long has it been, the duration, whether it's constant, whether it's on and off, whether it's been progressively worsening, whether anything makes it better or worse. I want to know mainly whether he has premature ejaculation or whether he has a problem maintaining erection. If penetration is possible at all, or does he just want a longer erection? Look, considering the causes of erectile dysfunction, for testosterone androgen deficiency, I want to know whether he has spontaneous erections in the morning, for benign nocturnal tumescence, and whether there's any changes in libido. Also, another hormonal important cause is thyroid disease, so any change in weather preference. Then vascular causes, asking for a past medical history of diabetes, hypertension, hyperlipidemia, fat in the blood, and if it's present, for how long, whether he's getting medication for it or he's just on lifestyle modification. If he's on medication, whether he's compliant, any complications of the diabetes or hypertension like chest pain, blurring of vision, whether he's getting his blood pressure or diabetes checked regularly or not. And then coming on to genital causes, whether he has any penile deformity, abnormal curvature, or penile plaques, any surgery in the pelvic area causing damage to the nerves, any trauma to the area, any low urinary tract symptoms for prostate cancer, whether he has any dribbling, poor stream, incomplete voiding, nocturia, polyuria. I'll do a psychosocial assessment, asking the heads questions, asking for stresses at home, work, also ask about his relationship with his partner. Whether he has problems with masturbation, helps to delineate whether he has a psychological problem or not. Then I'd come to asking about lifestyle questions. I'll ask about smoking, alcohol, any recreational drugs. I'll come to how his diet and exercises, especially as other CVS risk factors. I'll also ask for other vascular sites, like whether there's chest pain on exertion, there's pain on the legs, pain in the legs on exertion, whether there's a dyspnea on exertion. I'll ask for a family history of heart disease or stroke. Medication, particularly, I want to know whether he's on antihypertensives, antidepressants, nitrates, because sildenafil is contraindicated, anti-Parkinson's medications, certain medications that could cause erectile dysfunction, antidepressants. Coming over to the physical examination. In the general physical appearance, I want to know the body mass index, I want to know the waist circumference measurement, I will get his blood pressure checked, and I will do a complete cardiovascular examination, starting from inspection, palpation, and then auscultation, look for murmurs, look for added sounds. I'll do a complete genitourinary examination, looking at the penis, whether there's any abnormal curvature, whether there's any plaques, penile plaques, in the presence of a chaperone. And I'll also look at if there's any testicular mass. And I'll do a digital rectal examination for the size of the prostate, especially looking for prostatic cancer. If the patient has diabetes, I'll look at his feet, I'll look for sensory examination for peripheral neuropathy, and I will also do a fundoscopy. I'd also like to do a questionnaire, like a sexual health inventory for men, or the K10 questionnaire. The sexual health inventory for men has 5 questions. It asks for over a period of 6 months and has 5 possible responses for each. If the score is 5 to 7, it's severe erectile dysfunction, and if it is more than 22, then there is no erectile dysfunction. Coming to the differentials, I want to differentiate between premature ejaculation, erectile dysfunction, loss of libido. If it is true erectile dysfunction, it could be organic, psychogenic, and mixed. So if it is organic, it could be because of advanced age, obesity, metabolic syndrome, atherosclerosis related like diabetes, hypertension, hyperdyslipidemia, smoking, because of neurological conditions like Alzheimer's, Parkinson's, stroke, spinal cord lesions, peripheral nerve disorders like diabetic neuropathy, pelvic surgery, radical prostatectomy because of CA prostate, radiation to the area, trauma to the area, then endocrinological causes like hypogonadism, thyroid disorder, hyperprolactinemia, then penile abnormalities like Peyronie's disease, Psychological, psychiatric conditions, so partner-related causes, stress, guilt, situational anxiety, self-image problems, low self-esteem, history of sexual abuse, generalized anxiety, depression, psychosis. Then medications like antihypertensives, anticonvulsants, antiparkinsons, psychotropic medications, hormone affecting ones, and substance abuse. For investigating the patient, I would like to do a complete blood count, blood sugar level, fasting lipid profile, HbA1c if he's a diabetic, maybe even a liver function test, um, a TSH, androgen studies, maybe LH and progesterone prolactin levels, maybe a urine ACR, and PSA if required. Coming to the management, first I'm going to find the risk factors and address them, like a lifestyle, stopping smoking, healthy diet, exercise, reduce alcohol, avoid drugs. Then reinforce control of diabetes, hypertension, and hyperlipidemia, assess for cardiovascular disease risk. Then I would treat any reversible causes if they are found, like low testosterone and medication-induced erectile dysfunction. If there is any psychogenic component, then considering referral to a psychiatrist. First line pharmacological treatment includes a phosphodiesterase type 5 inhibitors like sildenafil. Others include tadalafil and vardenafil. Second line treatment is penile injections, vacuum erection devices, external shockwave lithotripsy. Third line is penile prosthesis.